thank you all for coming this evening. This evening's presentations are a portion of our Northwest District Continuing Education event through the Ohio Physical Therapy Association. So, in that interest, Dr. Michelle Masterson, I'm going to invite her up. She has a quick announcement. She is the Political Action Committee Chair of our district committee, and she has a quick announcement about our event afterwards. Thank you.
What an exciting night. Congratulations, students. This is great. And as Nicole said, the chair of our Northwest District, this is an Ohio Physical Therapy Association approved, sponsored continuing ed program. We have many clinicians that are attending for their continuing ed credit, and we do have a social hour at Gillig Winery afterwards for the clinicians here. And if you registered, we'll see you over there. If you haven't registered, come anyway. So we have some free food and some wine, and so students, you will stay here for your ceremony. We're going to go over to Gillig. So, but everyone's welcome, and again, congratulations, students. Thank you.
Okay, thank you very much. All right, so we'll get started with our presentations. I will ask that you hold all questions until all 4 presentations have been given by the students, just so that we can make sure that we give them the time that they deserve to present their projects. So I will ask our first group to please come on up, make your way up to the stage. This group is presenting on PT outcomes for individuals with headaches treated with dry needling with and without electrical stimulation. The faculty advisor is Dr. Deborah George. Come on up. You guys all know how to work this? Okay, so when you pull up your PowerPoint presentation, so somebody pull up yours, then press this to advance the slides, and this is a laser. Okay. Okay? Perfect. Okay. Should we advance our own side? Yeah, advance. Okay, it's just that arrow. Yeah. Okay. On this side? Just that.
Say cheese, everyone. All right, good evening, everybody. Thank you for joining us. My name is Curtis Munday, and as you all just heard, our group will be presenting our research project, which is on the outcomes of individuals with headaches treated with dry needling with and without electrical stimulation.
Okay, so as you can see here, these are our objectives that we wanted to look at for our study. So the first one with pain intensity, we had our therapists use the visual analog scale to document how intense their pain was with their headaches. And then for the second one with headache frequency, patients reported how often before getting dry needled, either weekly or, so they reported how often they were getting their headaches before getting dry needled, then each week during treatment, and at the end of their total sessions. And that was recorded on the questionnaires that we provided for them. And then with duration, this is where we documented how long their headache lasted, either in minutes, hours, or even days. And this was the same as the frequency. We took that at the initial session. We did it weekly during their treatments and again at the end. And then finally, for cervical active range of motion, we had our physical therapist use a goniometer for uniformity. Okay, so what is a headache? Well, just like it sounds, a headache is a pain in the head. These can be broken up into 2 different categories. So primary headaches originate from a chemical change in the brain and the head. These can include migraines, tension headaches, and trigeminal headaches. The secondary headaches, these come from a response to a disease, trauma, or other outside sources. such as sinus headaches, headaches with medications, and cervicogenic headaches, which is what our study mainly focused on. And we did this because it's very important. As you can see, it's the 6th leading cause of disability, according to the Global Burden Disability Study that we found. And then here's a little excerpt about the treatments that can be done to treat headaches, which can include medications, stress techniques, physical therapy, and most recently, dry needling. And this is just a diagram to differentiate the different categories.
All right, me, fun. So, just a brief introduction to further understand dry needling. These are a few photos, one of a person getting dry needled in the neck, hint, hint, our presentation. And then, I'm not sure what part of the body that is, I just Googled that one. But what they do is, they just insert a dry monofilament needle into a trigger point, and what that's going to do is help reduce the pain and tension in that muscle, so it pulls less on those joints and helps decrease the pain. A little bit of a background. So headaches are a very complicated medical ailment. They occur for many, many reasons. 45 million people complain about headaches every year. Then 8 to 45 million seek PCP care. Now, I do want to note that this number doesn't include the 33 members of the DBT transitional cohort, so we'll get those statistics later. Now, while dry needling can be done by itself, it can also be used in conjunction with electrical stimulation. And there's little research for that, but studies exist for other body parts, so we were chosen for the neck. Now, the purpose, wait, is this mine? This is not mine.
Okay, so the purpose of our study was to compare physical therapy treatments with dry needling for headaches with and without e-stim. We did this by using. Okay. We did this by using like pain intensity, headache frequency, headache duration, and then their neck range of motion. And then our hypothesis for the study was that dry needling with and without e-stim would decrease the frequency and duration of the headaches while also increasing the cervical range of motion.
So when gathering participants, we use convenient sampling. We did this by using our researchers and their home clinics. These were spread out between Ohio, Indiana, Kentucky, Washington, and Wisconsin. When looking at the participants to include, they first needed to be a candidate for dry needling and have no medical conditions to be excluded from that. They had to be 18 years or older, have excellent mental health and physical health, or they could also be already receiving dry needling. Some reasons to be excluded would be any medical conditions that the therapist felt deemed them to be excluded, history of neck trauma, surgeries, any radiculopathy with the neck pain, and then cognitive deficits and any legal litigations pending.
So we had a questionnaire, which is a participant headache questionnaire. It included patient demographics, the visual analog scale for pain, which is up there above the picture there. So no pain over on the left, 10 out of 10 pain or worst pain imaginable on the right, just kind of mark the spot. Then we had headache frequency, headache duration, and then active range of motion using a goniometer. So again, we had the two treatment groups. We had dry needling without e-stim and then dry needling with e-stim. And then the therapists, they were all trained based off of different certifications. So we led it up to them to kind of make the decision on the specifics towards their training. And then with the e-stim portion, they would just use alligator clips to administer the electrical signal into the targeted tissue. It was up to 6-week duration max, and then we'd use that same questionnaire before and after each session that they had dry needling administered. And then for patient confidentiality, they were given numbers, and The forms were kept in a lockbox. So here is that picture with the alligator clips, and this looks like an ankle. So again, Google. So the information, we uploaded it to a secure Microsoft Excel spreadsheet, and then we shipped it off to a statistician for analysis, which I think I saw her here tonight. So thank you for the help, wherever you're at back there. And we aggregated and analyzed our data using the Wilcox and Ransom test for non-parametric data, and that's where we could see the differences significantly or not significantly between the two treatment groups. Okay, so for the results, what did we find? So we had 5 total participants in our study. We had 4 from Indiana and then 1 from Ohio. Each subject had a different history in terms of headache characteristics, whether that could be the location of the headache, the intensity, duration, and the length of time that they had been experiencing the headaches. And that was anywhere from 1 month up to 10 years with one subject that we had. So like I said, 5 participants were included. The number of muscles that were needled per session just varied depending on the person. Again, we left it up to the clinician to decide with their training what they were most comfortable with. So it ranged from 2 to 10 needles per session. One individual received 26 needles in one session, and then average the others received roughly 2 to 6 per session. The most common muscles that were needled were the upper traps, the suboccipitals behind the skull, levator scapulae, and the cervical paraspinals. And then the number of treatment sessions for each individual for the length of the study ranged from 1 to 4. This slide here shows the changes in the frequency and duration of the headaches for our 5 participants. So you'll see the lines labeled in the highlighted sections. Those are the individuals that received electric stimulation with dry needling, and then the non-highlighted sections are those that received the needles only. So on the left side, if we look at frequency, the one individual went from 7 headaches to down to just once a week. The next one went from 1 to having no headaches. The next one went from 2 to 4 times a week to just once, and then 3 times to once a week, and then there was no change reported in 1. I won't go through and read all these since you can see these for yourselves, but we also see some good changes in duration as well. One thing I do want to point out on this slide is there's a general trend towards a decrease in frequency and a decrease in duration for participants of both groups. And then if we look at the duration in the electric stimulation group, we see that it's maybe not quite as much as the individuals who had the needles only. This slide gives us the results in terms of intensity. So same thing with highlighted and non-highlighted. And this is actually pretty significant because the individuals who received electric stimulation and the needling, you'll see their pain ratings went from 8 out of 10 to 0 out of 10 and 10 to 2. So those are pretty substantial decreases. If we look at the subjects who just had the needles alone, there were actually no improvements in intensity of their headaches when they did actually experience those headaches. If we look at cervical spine range of motion, we measured cervical spine flexion, extension, lateral flexion, and rotation bilaterally. We found the most limitations within flexion and extension in most of all the participants, and therefore we saw the best improvements in those 2 movements.
Within our study, we found quite a few limitations. As Curtis just discussed, we got 5 participants, so it's hard to gather a ton of data from that. With that low data, we found limitations within our study to design. That was the limited participants, as well as just having a short time frame with doing this within like our semester's time, and that gave us that minimal data. We also had limitations within those patient preferences that reduced the amount of people that we were able to include in our study because of, 1, therapy costs, people not wanting to continue with treatment. We had some reluctance with paperwork to gather the data, and then as well as just having a general low caseload of dry needling during this time.
Another limitation was the therapist preferences. So one clinic did not use e-stim with dry needling because they viewed it as painful for their patients. whereas other clinics that we had, they preferred to use e-stim with dry needling. Another thing is the therapist had preferences on the needle size and the placement, so they could place them in different areas of the musculature. And then also there was little communication between each therapist because this took place over multiple different states. So they did not know each other and no communication. And then finally, there was reduced awareness for services, but we combated that with advertisements that we put up in the clinics.
So taking those limitations and trying to improve upon them would be our future recommendation for the research. So it's going to be to increase that sampling size through more researchers, more clinics, more clinicians, as well as extending that time period that you collect data. We recommend that to be a year, 6 months to a year, in order just to gather more participants in order to expand on what we found in the analysis. We also recommend establishing a protocol. We found a lot of differences between therapist preferences on how they're implementing it and what they're doing within treatment. So for the next research, we would recommend to consolidate and choose one protocol to follow.
So in conclusion, we found that there was really no statistical significance with our study, mostly due to the small sample that we were able to perform this research on. Although there were improvements of pain with the e-stim compared to the no e-stim dry needling, as well as all patients did have a decrease in the duration, frequency, and intensity of their headaches. So this would warrant for further research to be done to see if we could find some statistical significance with these patients. And then any questions?
Great job, everybody. Nicely done. Okay, so now I'm going to ask our second group. We're just going to keep right on going. So I'm going to ask our second group to come up. They studied the effects of a 6-week core and pelvic floor strengthening program on the athletic performance, low back pain, and pelvic floor dysfunction of female collegiate athletes. And this group is advised by myself, so come on up. Students, as you guys are talking into the microphone really quick, if you could get really close so everybody could hear, that would be great. This does not come out, so you can't take it out, but please make sure you're getting really close. Thanks.
Just click the next button.
Click the next button, and then this is a laser if you need it.
How will we play the video?
Yep, if we click the little, like if the right here, like clicking, I'll go down there. I'll play the video. I have it set up so I can click through it real quick. So I think it'll play. Okay, I'll be down there just in case. Okay. Click it. How many feet it is? 600 bucks. What? I guess we'll find out if it moves that one. Okay.
Hello, my name's Jennifer, and our study looked at the effects of a 6-week core and pelvic floor strengthening program on athletic performance, low back pain, and pelvic floor dysfunction of collegiate athletes. So literature reviews have revealed that 80% of female athletes experience pelvic floor dysfunction in the form of urinary continence due to core muscle weakness, low back pain, and pelvic floor dysfunction, which leads to decreased athletic performance. Core strengthening exercises are a common exercise prescription, but the evidence is limited and conflicting, which lead to the purpose of our study. So then, our purpose of the study is to assess if a core and pelvic floor strengthening program changes athletic performance or subject report of low back pain or pelvic floor dysfunction through the upper and lower abdominal manual muscle test, core endurance, the T-test, hexagon test, single vertical jump, quadruple, and the quadruple vertical jump test.
So we generated 6 hypotheses to see if this core and pelvic strengthening program would affect vertical jump and agility, as well as low back pain and pelvic floor dysfunction.
My name's Brianna. In the subjects of our study, we included 34 participants. There was 16 in the control, 18 in exercise. And they were included in the study if they participated in a collegiate sport, a female volleyball, soccer, basketball, and if they were just able to provide written consent. They were excluded if they were under 18 and unable to provide consent, if they were pregnant, they had any orthopedic surgeries within the past 6 months, and if they had a musculoskeletal injury that resulted in them less playing time in the last 6 months.
So we had 2 testing sessions, a pre and a post test over a 6-week period. We looked at the incidence of low back pain, pelvic pain, urinary incontinence, and fecal incontinence. At pre-test, we asked them if they experienced any of those previous dysfunctions within the last 6 months and the last week. And then at post-test, we asked if they had them within the last week. And then lastly, subjects were randomly assigned into a control or exercise group, where the exercise group was given specific exercises to strengthen their TRA, lower abs, hip internal and external rotators, and pelvic floor based on assessment results. And then the control group was instructed not to change their current routine.
Okay, so my name's Ethan and I did data collection. So we verbally collected each patient's or subject's age, sport, anthropometrics, self-reported low back pain, and pelvic floor dysfunction. For upper and lower abdominal MMT and core endurance, we used the ACSM guidelines, and we performed 1 trial for that one. For the T-test, hexagon test, and single vertical jump and quadruple vertical jump, we used the NSCA guidelines. So for the T-test, we did 2 trials and took the best trial for that one. For the hexagon test, we did 3 trials and took the best one. For the single vertical jump, we did 3 trials, took the best one. And then for the quadruple, we did 2 trials and took the best one.
So for the upper abdominal strength test, we tested that via the manual muscle testing procedures. We had the subjects lie on their back in the supine position, and they performed a trunk curl by flexing the spine with their legs straight. The feet were not stabilized, as this would allow the hip flexors to initiate trunk flexion. The test was then graded using the Kendall text and was based on the amount of spinal flexion the subject can perform without assistance or performing hip flexion. A normal score, which was a score of 10, would indicate that the subject is able to sit up with their hands behind their head without flexing their hips. So the first 2 pictures, those 2, would have shown a score of 5. And then if the subject was able to sit up with their hands at their side, but with hip activation, then they would be scored as unable to perform. And then the last 2 pictures would have shown a score of 6.
So for lower ab strength, it was assessed by having them lay on their back, and I placed my hand under their low back and informed them to flatten their back on my hand or do a posterior pelvic tilt. And then they raised both of their legs up straight in the air, and I had them maintain the pressure on my hand while they slowly lowered their feet to the ground. And using this grading system, I assessed where I felt them lose the contact with my hand. And in this picture here, with that angle, it's giving them a grade of 7.
All right, so the next one was core endurance, which was assessed by having the subject perform like a partial curl up with their arms at their side. They would lie down on the mat with 1 piece of tape that was placed at their fingertips, with the other piece placed 12 centimeters away. They were instructed to perform the slow controlled curl up, lifting their shoulder blades up with going to a metronome that was set at 40 beats per minute. They were graded on the number that they completed, that they performed without pausing and still going to that metronome, to a max of 75. In these images, the first one, you can see that she is in the starting position with her fingertips at the blue tape. And then in the second one, she's performing the curl up, reaching for that second piece of tape.
So I helped administer the T-test, which essentially is a measure of lower extremity agility and athletic performance. So as you may have guessed, the design for this test, we set up 4 cones in the shape of a T with a start cone and then a cone straight ahead 5 meters in front of that one, and then a cone 2.5 meters to the left of that cone and 2.5 meters to the right of that cone. And so as Ethan mentioned, we did 2 trials. We would give a cue for the subject to start, and they would sprint to the cone straight in front of them, touch it with their hand, shuffle to the left 2.5 meters, touch that cone with their hand, shuffle back to the right all the way to the far right cone, and touch that cone with their hand, shuffle back to the middle cone, touch that with their hand, and then backpedal through the starting point. And then we timed those trials to the nearest 1/10 of a second and took the better of the 2 trials, which an average time for females is about 11.5 to 12.5 seconds.
All right, so I'm Patch. I administered the hexagon test. So for this, we obviously put a hexagon on the floor. It was 2 feet for each side length and equal angles across. We'd have the patient jump from the center outside each side, and they would repeat around in a circle 3 times, and we'd do 2 trials of this. We actually have a video, if we go to the next slide, that will demonstrate this better. Well, we might not have a video. So basically what they would do is jump from the inside of the circle to the outside against each side. They'd go around 3 times. It's the normative score for this would be around 12 seconds for each individual for female athletes, and we took the better of the 2 scores. Can you demonstrate? Sure. So, if there's a hexagon here, you go.
So then we measured the vertical jump, the single and the quadruple vertical jump via the Just Jump pad. And then we actually also have a video for this, maybe. And I'm not demonstrating. Yeah, no way. No. But we did do, we had each patient do a power bound jump to keep the test consistent, and then the average for that was 12 to 16 inches.
All right, so for our results, we kind of put these graphs together to just kind of make it easier for you guys to see. We were not able to find a lot of statistical significance for the scores, but we were able to find it for the 4 times vertical jump was statistically significant between the control group and the exercise group. As well, we were able to find that between the pre-test and the post-test for both groups, the hexagon test was statistically significant. It might not look like it because the bar on the right is lower, but some of the tests were for time, so that's why some of them may be decreased for the post-test. Additionally, we kind of attributed the hexagon test decreasing to people learning how to do the test. As I just demonstrated, it's not the simplest test, so once they learned how to do it, they were able to improve their score.
So our conclusions, a 6-week core and pelvic floor exercise program may improve female athlete in repetitive jumping performance via the 4 vertical jump test, but it may not improve athlete agility or max vertical jump height. So our study revealed that an exercise program, including the pelvic floor strengthening intervention, may benefit athletes due to reported incidents of pelvic floor dysfunction. And from our subjects, 40% of them reported low back pain, 43% reported pelvic pain, and 20% reported urinary incontinence.
So looking at our study now holistically, so like Patch mentioned, we did find statistical significant improvements in the repetitive jumping, the 4 times vertical jump test, in comparison to the control group, but other athletic performance variables such as the T-test and the hexagon test improved, but they did not meet statistical significance. Then the control group improved slightly in the T-test and the hexagon test, which limited the ability to achieve that statistical significance. And we thought that the control group may have improved due to a secondary motor learning effect, meaning that they came the first time, weren't exactly sure what they were doing, but when they came back again for the post-test, they had a better idea of how to do the test, or perhaps gave a better effort the second time around, or just had an overall increase in core strength and endurance due to doing their own independent strengthening program, maybe with their respective sports team. So then maximum vertical jump test did not improve. We thought this could have been due to being more of a power activity, which requires a high level of strength over a shorter period of time, as opposed to endurance, which requires a lower amount of strength over a prolonged period. And then lower abdominal strength and core endurance did improve for the exercise group, but upper abdominal strength did not. We thought this might have been due to our exercise prescription focusing more on lower abdominal strength as opposed to upper abdominal strength, or having an overall lack of adherence from the exercise group doing the exercises as we prescribed them, or the lack of overall supervision to that same prescribed home exercise program. So then other limitations for our study, we did not reach the power of 0.8 that we were shooting for due to 4 subjects withdrawing, which limited our ability to achieve that statistical significance. The control group may have been participating in their own core strengthening, like I mentioned, with their own respective sports teams doing off-season workouts. And then again, that non-compliance, not performing the exercises as the exercise group was prescribed. So overall, what does this mean for us as therapists clinically? This study does align with previous research in showing improvements in some areas related to athletic performance without any adverse effects, but larger samples with controlled interventions and extended follow-up periods may be necessary to help support this theory. And these are our references.
Nice job, everybody. Bonus points, Patch, for the demonstration. Okay, then I'm going to ask our next student group to come up, and I will let you guys introduce yourselves since you're here.
All right, so our research was on the effects of attentional focus on lower extremity kinematics in gluteal, both medius and maximus, muscle activation during common therapeutic exercises. And then all of us did it with advisors Dave Veerhoff and Angie Huber. So as far as for the introduction here, so our research question was, does attentional focus affect gluteus medius and gluteus maximus muscle activation in lower extremity kinematics during commonly prescribed therapeutic exercises such as the ones listed here? Our purpose for this study is to investigate the impact of commonly used internal and external focus instructions on the activation of gluteal muscles and the kinematics of the lower extremity during performance. So we used 2 different types of cueing. We used internal cueing, which is when the concentration is focused on the body movements themselves. So an example of this is when you're doing a squat, we're going to say focus on keeping your knees from going over your toes. And then we have external cueing, which this is when the concentration is directed towards the outcome of the body movements rather than those themselves. So with this, an example would be with a squat, we're going to say pretend like you're going to sit in a chair. Our hypothesis for this study was that external attentional focus cues will increase gluteus medius and gluteus maximus muscle activation, as well as improve lower extremity kinematics during these common exercises. Our overall goal is to continue to expand our knowledge of the proper instruction so we provide the best feedback for our patients. So then into the methods. We completed a randomized quantitative experimental study that included 16 participants that were classified as healthy adults. We asked each participant to complete 5 commonly selected exercises that target gluteus maximus and gluteus medius activation. These exercises included squat, single leg squat, side lying clamshell, side lying abduction, and single leg bridge. The participants completed 2 reps of each exercise, 1 rep with the internal cue and the second rep with an external cue. These cues were alternatively provided and the starting cue was based off of a coin flip. These cues were chosen based off of a survey that we sent out to PTs and PTAs asking for them for their most common cues used for each of the previously mentioned exercises. To collect our data, we utilized the Neuraxon Myo research system. So we used 2 different types of sensors to collect our data. The first sensor was an initial measurement unit, also known as IMUs. These are used to collect 3-dimensional kinematic data of the knee, hip, and trunk bilaterally. So you can see here the black bands around both of her legs there. Those are going to be your IMU sensors. There's also one around her trunk. You just can't see it as well because she has a black shirt on, but those are going to be your IMUs. The second sensor that we used was a surface electromyographic data, or a surface EMG. These were used to assess muscle activation of the dominant side lower extremity. The specific muscles that we measured were the anterior tib, the lateral gastroc, the lateral hamstring, the rectus femoris, gluteus medius, and gluteus maximus. You can't see them as well. The only one you can really see is that one there. Those are just going to be small little sensors that stick on the skin, and we place them precisely on those specific muscles. And then here we have a chart that represents the attentional focus cues that we utilized. I won't read them all to you, but for just explanation of the chart here. So the first column there, that's going to be all of our exercises. The second column then is going to be our internal cues, and then the third column there is going to be our external cues. So some of the highlights that I wanted to point out here are that our internal cues are focusing more on those specific movements of the body parts themselves. And then our external cues are focusing more at objects outside of the body and then the outcomes of those body movements there.
Okay, so then to analyze our results, we used a Wilcoxon signed rank t-test, which gave us the p-value, and for this study we selected having a p-value of significance be one that was less than 0.05. Additionally, we did a descriptive statistics analysis to get the median values for both the internal and the external cueing. And on this chart, this one shows the muscle activation. So for that, the median value represented the percent MVIC, which we later compared to show which cue elicited greater muscle activation. So what you can see for the squat is that the internal cue provided a higher MVIC for the gluteus maximus, meaning that the internal cue elicited greater glute max activation with the squat. And then similarly with the side-lying clamshell, the external cue provided a more significant activation of not only the glute max but also the glute med. And then the single leg squat, it had a greater response to the internal cue rather than the external cue. And then there were no significant results found for the single leg bridge or the side-lying abduction. And then this is a chart of all the kinematic results, which we use the same kind of statistics to analyze it, except the median represented the degrees of the kinematic movement. So for example, the first one we were looking at hip flexion, And for the squat, it showed that the internal cue elicited greater hip flexion than the external cue. And then for the single leg squat, it showed that the internal cue gave a greater degree of hip flexion and knee flexion. And then the side-lying clamshell, the external cue elicited a greater degree of hip abduction, hip external rotation, and knee flexion. And again, these were taken by the sensors that Brooke had previously shown you of the IMUs, which were on the designated joints. And again, there were no significant findings for the single leg bridge or the side-lying abduction.
So this table gives an overview of how gluteus medius and gluteus maximus responded to an internal and external cue. Additionally, it provides insight on if the variables altered in our study had an effect on the benefit one receives from exercise. Research shows that an MVIC of less than 40% promotes neuromuscular activation, while an MVIC of greater than or equal to 40% promotes significant strength gains. So some of my main takeaways from this table is that for all of the exercises except the clamshell, cueing did not alter whether the exercises elicited strength gains or neuromuscular activation. This means the type of cueing did not cause the MVIC to cross that threshold set at 40%. Because this table simply looks at strength versus neuromuscular activation, it is important to keep in mind that the cueing, as mentioned in the results, can still affect the overall muscle activation. The clamshell primarily produces neuromuscular activation. However, if an external cue is used, it promotes strength gains of the gluteus medius only. The bodyweight squat produced only neuromuscular benefits to both the gluteus maximus and gluteus medius, no matter the cue.
All right, so now on to the discussion and conclusion. So Isabella and Cheyenne kind of already talked about the significant results. We just got them in words right there for you to read. But aside from the significant results, some other takeaways from this study was that there's no exact pattern identified in the study. There was variability, so that goes in behind the execution and performance of each exercise, which I'll kind of talk about on the next slide. But it's also important to know that more research needs to be done on the effects of tensional focus as well as the types of cues provided. So in terms of variability in the study, some things that come to mind are just the different body structures and types. As we all know, bodies come in different shapes and sizes, as well as minds have different thought processes. So that kind of influences how exercises are performed. Not all exercises are performed the same way due to the different thought processes and body structures. Therefore, it's important to choose the appropriate cueing and detailed cueing in order to get the desired outcome for each exercise, which of course requires focus. So that leads me into my next topic of discussion, which is the types of cues provided. So cues can be provided and portrayed in multiple ways that would influence our results, which were based on the different muscle activation as well as different kinematics. So the cues we specifically noticed that could have altered our results were more on the external cueing. So in terms of external cueing, they tend to rely on imagination as well as physical objects. So in our study, we had the single leg bridge, and the cue for that stated, lift one leg off the table, form a bridge to allow a boat to pass underneath you. That cue had the imagery or imagination focus to it, and then that showed no significance, whereas the clamshell exercise that did show significance had more of a object-focused cue, and that cue was open up like a clamshell, reaching up towards my hand without rolling back. So knowing that there's kind of some gray area in the external cues, specifically the ones that rely on imagination or imagery, could have altered our results. So knowing that not all boats are the same sizes, not all bridges are flat, some are arched, that could have skewed the results a little bit because it relied on the patient's imagery and execution. So with that freedom that comes with imagery-focused external cues, again, that might have influenced our results. Another thing that we noticed was that there was another thing we thought that could have influenced our results was that not all exercises were demonstrated prior to the exercise.
So again, if somebody was unfamiliar with how to perform this exercise, they may rely on, well, they're definitely relying on the cue, but again, it might have them go back into that imagery-focused cue, which could eventually influence the results. The last thing that we thought had to play in the influence of the results would be the participants only had one rep per exercise per cue. So it'd be nice to do a further study, adding more reps to see how that may influence the results. And then with all that being said, more research needs to be done to understand the effects of attentional focus, as well as how the cues influence exercise execution.
So when you conduct research, it's important to compare how it is to different research in the same field. So look at the first study by Wolf in 2013. There's a quote that says, "Performance and learning advances with the adoption of an external focus relative to an internal focus have also been demonstrated." Wolf performed a comprehensive review of attentional focus in 2013, and Wolf discussed several different objective measurements that together replicates the performance of the exercise. Therefore, our results that indicate external cueing increased glute med and glute max activation during clamshells co-align with Wolf's statement that external focus cueing improved performance of the exercise. Go into the next article by Singh in 2021. That quote reads, "An external focus of attention offers an alternative strategy that facilitates automatic movement control and results in more effective performance and learning than internal focus of attention." This was similar to Wolf's study in that with lower extremity kinematics, they were improved with external focus cueing. In our study, the clamshells were similar in this sense, in that when we gave external cues, they improved their kinematics through increased they improved with hip abduction and external rotation, which is necessary for clamshells. However, when we gave internal cueing, that improved the kinematics of both single and double leg squats by increasing the amount of hip and knee flexion, which would result in a deeper squat. The last article is by Ebert in 2017. That article indicated that the MVIC greater than 40% have greater potential for strengthening effects, and that MVIC less than 25 have been reported to improve muscular endurance. As Cheyenne previously mentioned, we had several exercises that would reciprocate either the strength or endurance MVIC levels. However, during the clamshell exercise, external cueing resulted in MVIC that correlated with muscle strengthening, while internal cues correlated with improved muscular endurance. Ultimately, as we have mentioned, most of the recent research indicates that external cueing improves kinematics and performance of selected exercises. The primary idea seemed evident when the participant in our study was completing the clamshell exercise, but with external cues.
Now to clinical relevance, or how you can take what you've learned today into your clinical practice. So first, we must understand the different types of cues, remembering that an external attentional cue focuses on giving concentration towards the outcome of a body movement, while an internal attentional focus cue gives concentration to the body movement itself. Second, we should reflect upon our practice. Identify which cues you often resort to using. Do you tend to use internal cues or external cues in the clinic? Get creative with your cueing to achieve the results you want. And 3, recognize the impact. Knowing how cues affect the performance and execution of each exercise can help patients receive the most beneficial treatment possible. So in conclusion, our takeaway is to consider the use of both internal and external attentional focus cues to arrive at the optimal movement performance of an exercise. And we will be accepting questions after all the presentations are completed.
Great job, everyone. Okay, and now I would like to invite our last presenter up to the podium to present on physical therapy care management and interventions of a patient with inclusion body myositis, a retrospective case report. Take it away.
Am I able to take that out? All right, I guess I'll be guess I'll be batting cleanup here. All right. My name is Christopher McKay, student physical therapist, PTA. So my presentation is on, like I said, the physical therapy management of a patient with inclusion body myositis. First of all, what is inclusion body myositis? It's a chronic degenerative disease that is slowly progressive. It affects males 2 to 1 over females, and usually over the age of 50. As you see, I can see in the picture there, it mostly affects the quadriceps muscles, the finger flexors, and less commonly the anterior tib. Some other patients with more progressive version of this also complain of difficulty with swallowing. So the patient was a 65-year-old male with an 8-year history of progressive lower extremity weakness. He did say that he had family history as well, that his father also suffered from weakness in his legs. He mostly came in because he felt weak at the knees, especially with navigating stairs, going down especially. 10-year history of low back pain. Again, like I said before, mild dysphagia to solid. So this patient did have more of a progressed version of this. He actually did exercise about three times a week, yet he still had this weakness. And so that's what brought him in to physical therapy. He has a history of heart disease, among other things there. And then he was finally diagnosed with IBM in 2020. The only way to diagnose IBM is through muscle biopsies, which he did have done. As you can see in the picture, over to the right, that's a more advanced stage. That's not the patient himself, but as you can see, the musculature within the arms, and again, within the quadriceps as well. So this patient, again, was complaining about his knees buckling, especially when going down the stairs. Decreased eccentric control with transfers. He did mention that his laundry was downstairs, so carrying a basket downstairs, again, it was not safe for him to do. He was not stable in his abdominals. Again, poor control of the pelvis itself, and he was not able to get up from the floor. Again, this patient was 65 years old, but he was working out regularly 3 times a week. So during the examination, weakness noted bilaterally, as you can see within the, oh, my bad, there we go. Does this have a, whatever. So you can see in the MMT scores, left versus right, left was a little bit more weak, especially within the glute medius and the glute max. Trunk range of motion was decreased, which is not surprising given his history of low back pain. Like I said before, too, decreased eccentric control with the functional mobility assessment. And then he was negative for the straight leg raise, and then decreased muscle length in the hip flexors and hamstrings as well. So interventions were started out pretty traditional, given that the physical therapist was not familiar with IBM. So she mostly hit on the deficits in which the patient was presenting with. So working a lot on the quadriceps muscles. However, throughout researching, she did move to more functional activities that he was more complaining about, such as transferring sitting to standing, stair climbing, and the such. MedBridge was used for HEP builder and tracking. It's a wonderful program that she was able to track how he was doing his exercises, the frequency and the duration in which he was doing them. He was spending about 2 hours a day on exercising itself, and 5 days per week. So the care management is not particularly traditional with somebody who's just a plain orthopedic ailment. It was more of a lifestyle change. This was a chronic degenerative disease, so physical therapy and the management of it was leaning more towards maintaining what he had, given the progressive state of it. So through the results, so the duration of this study took over about 5 months. The patient was seen one time per month. Again, that's a little more unorthodox. Usually you're seeing 2 to 3 times a week. However, this patient was not going to get any better just coming to physical therapy 2 to 3 times a week. He had to do the work himself. So as you can see, he improved to 5 out of 5s for most of it. He did not have any change with his grip strength, however, and his 5th finger digit pinch did improve some. However, those tests were actually done 1 month after the evaluation. So given that the physical therapist knew a little bit more about IBM, she added a few different tests for it. Interesting enough, there was no change in thigh and calf circumference. We might have expected to see a little bit more improvement with that, but again, he was more in a more progressive state of it. And so now it's physical therapy, the goals for it was more maintaining his functional ability. So again, this patient was highly motivated. You got 2 hours per day with exercises. That takes a significant amount of devotion. He did improve in all areas, and then the physical therapist used the lower extremity functional scale to begin with. However, he did score lower at discharge, interestingly enough. So functional outcome tests were not really captured during that time frame. But subjective matters, he did improve. He showed that he did improve in his grip and his ability to grasp the laundry basket. He reported no incidences of knees buckling. He felt more stable on his feet. So in terms of kind of going from there, what type of research is out there for it? There's a few different studies out there, but again, it's a more unique disease, and so there's not many people that have it, especially in one area, that you could perform a prospective study on in terms of an RTC. So what we did with the research is high intensity interval training is one that I kind of looked into a little bit more as well. And studies have shown that, that the patient actually does improve with high intensity. However, you got to manage what the intensities are. You want to avoid DOMS, which is delayed onset muscle soreness. However, you need to properly fatigue those muscles. Biofeedback EMG would be a good visual for, at least for the patient himself, to be able to see if he's activating the correct muscles. Blood flow restriction is another newly tested theory, and recent studies that are within the actual research say that BFR is a good intervention, and studies have shown that people do improve really well with this without damaging tissue. Again, objectifying the intensity of the daily exercise program is a factor that needs to take into account too. How intense is he doing his exercises? So further studies might warrant a little bit better with that. Just kind of going down the list. Quantify MMT scores. There might have been more of a ceiling effect with this one, especially with this patient. So handheld dynamometry would have been a really good area to show more improvement with that. And again, identifying proper functional outcomes. The physical therapist only used a subjective outcome, and so the functional part of it was not captured really well within the study. And again, it all comes around to patient care. So it's the physical therapy management. So it's a little bit different management than what the traditional is. And so the overall goal is maintaining function and improving safety. And there are my references. Thank you very much.
Okay, so we have about 9 minutes for question and answer. So at this time, I would like all presenters to come back up to the stage, please. And if you have any questions for our presenters, I'm going to ask you to come to this aisleway, or at least make your way up towards the front of the stage. We do have a portable microphone that we will ask you to use so that everyone can hear your questions. So come on up. Please don't be shy if you have a question.
So again, everybody's different how they recover. Through this patient himself, he didn't exhibit any extra time that he needed to recover. He did a good job at avoiding the DOMS, and again, properly fatiguing the muscles so that the muscles could have that physiology effect of improving themselves. Again, but this patient didn't exhibit that.
Any questions?
You mentioned on MedBridge that the therapist was monitoring the patients and what they were doing outside of being in therapy. How did they prescribe intensity? So how did the patient know if they were doing the exercises at an intensity the therapist wanted? If they were exercising that much a day? Was there some kind of guideline for the patient for intensity?
Yeah, so with MedBridge, you're able to put sets and reps to each of the exercises. However, again, you could say three sets of 10 and call it good. But no, that wasn't the case, especially with this patient. There's also notes that the physical therapist did say is go to when you're tired, and then do a few more reps after that. So there wasn't really a set amount of reps, but make sure that the muscles are feeling that they are getting tired.
I have another question for Chris. Just kidding. I have a question for the dry needling group. So I know you had a small sample size and you had a lot of variability in the treatment. This might not be something that you analyzed, but did you notice any correlation between the muscles needled and decreased symptoms with the subjects?
I guess is not a great answer, but yes and no. I think a lot of the subjects that we saw, all 5 really, those 4 or 5 muscles that we listed, almost all the subjects had those needled. The 2 to 6 needles that were placed for each session usually correlated with upper traps and suboccipitals were the main 2 that we saw. I'm going off memory. I believe every single participant had those 2 muscle groups needled every time.
Any other questions? One more time. Okay, well, on that note, then you guys can come on down. So this does conclude the continuing education portion of tonight's events. So to all clinicians, you are welcome to stay for the white coat ceremony if you would like. However, you are also more than welcome to head on over to Gillig and get some wine. If you are staying for the white coat ceremony, we will take a really brief kind of intermission here, about 8 minutes worth, and we will start the white coat ceremony at 6:20.